why are we covering genomic medicine today? So it comes up in your curriculum and it comes up in exams, and that's all fairly political, actually, which we'll talk about a tiny little bit later. And it is actually relevant to what we do in our jobs. It's relevant to lots of specialties in medicine, and it does come up in general practice probably more than you think. And I think going to the future, it's something that we'll probably hear about more and more. It has a massive role in cancer care, and I think it probably will evolve into other areas of medicine going forward, particularly with drugs, medications, treatments, all of those sorts of things, and this whole idea of personalised medicine, which comes from knowing a bit about somebody's genetics and knowing what might work and what might not work. So I think it's very interesting, and hopefully you'll take something away from this today. So what we're going to cover, so I'm going to do a bit of a quiz just to start with, which is kind of refreshing all of our basic genetics knowledge. It's a bit kind of like medical school stuff, but I think it's useful, and actually some of it does pop up in your exams, and it's some of the basic stuff, so hopefully that will be helpful. Then I'm going to talk a little bit about how genomic medicine has come to be a thing, and how we talk about genomics rather than genetics these days. Then we'll have a little break, and then I'm going to just go into a bit more detail into a couple of conditions that we do see slightly more in primary care, and where we actually can have a role in genetic testing in primary care locally. And then I'm going to hopefully put you in some breakout rooms to do some AKT questions, then we'll come back and go through those all together at the end. So hopefully that sounds okay. So the first thing is a quiz, and we'll do this as a big group, but you might just want to grab a pen and paper if you've got one to hand. Don't worry if you don't, it's not too taxing. So the first question, what's the difference between genetics and genomics? So A, there's no difference, someone's just changed the name. B, genomics is about the protein coding genes only. Or C, genomics is the study of all of our DNA and not just the protein coding genes. So I'd be grateful if some of you want to shout out an answer for this one. They're not too hard, and there's no pressure if you get it wrong. Anybody?
C?
C, yeah, fantastic. Great. So genomics is the study of all of our DNA, and it's not just the protein coding genes. So the complete set of DNA that we've got in our cells is called our genome, and actually it's only a very tiny percentage of it that's made up of protein coding genes. It's only 1 to 2%. The rest of our DNA actually can have important roles in how our protein coding genes function, so what turns them on and off, and in which cells they are turned on and off in, and that's studied more in a genomic field called epigenetics. So some of this, kind of 98 to 99% of the DNA, is thought to be junk DNA, but that's probably just because we don't know what it all does yet. I imagine it's all rather important since we've kept so much of it for however long we've been on this planet. So I imagine it's pretty important stuff. So how many genomes do we have? 1, 2, or 3? Any thoughts? Slightly trickier.
I mean, 1, but presumably not, given the question.
Yeah.
It's mitochondrial DNA, isn't there? I didn't know.
Yes. Yeah, exactly. So we've got 2. So we've got our nuclear genomes, so the one that's in the nucleus of our cells, and we've also got our mitochondrial genomes. So extra bonus question, does anyone know which parent we inherit our mitochondrial genomes from?
From the mother.
Yeah, exactly. Do you know why?
I think during the embryo life, I think we just have the nuclear cell from the male side and hold them ovum from female side, so they mitochondria will be present.
Yeah, exactly. So the egg, the ovum, is a massive cell. It's got loads of mitochondria. The sperm is just DNA in a kind of moving body. So it's the mitochondria from the mum that we keep. So any mitochondrial conditions or conditions that are inherited through the mitochondrial genome come from the female line in the family. Great. So our nuclear genome is arranged in chromosomes. How many chromosomes do we have? Anyone remember?
well done.
John knows.
Physics pairs.
23 pairs.
What was that, sorry?
23 pairs.
23 pairs, yeah, fantastic, great.
Well done, Craig.
John's like, I know.
So we have 22 autosomes and then 1 pair of sex chromosomes, so XX for female, XY for males. How do we make protein from DNA? So can anybody remember the names of the processes of A, B, and C? So I think A and C are probably the easier ones. B is a bit more niche, so don't worry if you don't know it.
I think if I remember, transcription, translation, and something.
Yeah, so which one's transcription, which one's translation?
I remember.
Okay, yeah, fine, cool. Shall I give you the answers, or does anyone else want to have a guess?
Come on.
So we've got 2 other words. So transcription is A, so that's where you go from your gene to your RNA, so your DNA to your RNA, and then translation is where you make the protein, so that's C. Anyone remember the bit in the middle? No, so that's splicing. So your gene is made up of introns and exons, and your splicing just removes the introns. So it's only the exons of the gene that are made into your protein in the end. And translation uses some complicated machinery to essentially attach an amino acid chain together by reading the code along the RNA. And that happens within, the translation's in the cytoplasm, transcription's within the nucleus. Okay, so onto some family trees, and this is potentially useful, hopefully, for your AKTs, as this can come up. So if you want to jot down what all these different symbols mean, and then we'll just go through them, or feel free to shout them out, that's probably more fun. So anyone for A?
Male.
Yeah, great. B?
Female.
Great. What's C?
Deceased male.
Deceased male? No.
Affected male.
Affected
male.
So that's D.
Deceased female.
Affected female.
Affected female.
Sorry, affected, sorry.
How about E?
Deceased
I
male
think
and
deceased.
female.
Yes.
Yeah, so line through them, that means they're dead. How about F?
Is your patient or the person?
Patient.
Yeah, exactly. So in genetics, that's referred to as the proband, but it's just the kind of reference patient that you are dealing with as a doctor, and then building the family tree from them. How about G? Any thoughts?
Carrier.
Carrier, yeah, exactly. How about, I'm just moving my screen, how about H? Not sure I can remember these ones. H or I, anybody?
I, twins.
No, not quite. I'm going to give you the answers. So we got them all right. The diamond one is just if you don't know the sex. And the triangle is a kind of a loss of pregnancy, so that can be all sorts of different things. Twins tend to be where they've got a double line between them. So I don't know if you can see my mouth moving, probably not.
Yeah, come.
Oh, you can. So if you were to put a line between those and they were someone's children, that would then be that they were twins. Great, well done. Okay, so next 2 slides, we're just going to go through some family trees and work out the inheritance patterns of them. Can you remember the of inheritance patterns that we have?
Autosomal dominant.
Yeah, so autosomal dominant, definitely.
Autosomal recessive.
Yeah, perfect.
And X-linked.
Excellent. Yeah,
Recessive and X-linked dominant.
yeah, great. Cool, so they're the main ones. Have you got any others?
Mitochondria.
Mitochondrial, yeah. Okay, great. So, first one for you, what type of inheritance might this be? Any guesses?
I think autosomal dominant,
Yeah, cool. Why do you think that?
every generation.
Yeah, every generation. Good.
Yeah, male and female.
Males and females affected. I don't know if I can do that.
Yeah, just need to give the participants.
Okay. So I just need to let somebody else in that's in the waiting room.
You might even need to stop screen sharing and I'll just do it.
Okay.
You can go to participants. And then there you go, admit all.
Admit all.
Thank you.
Great. So welcome, the two of you. Sorry if we just lost you for a moment. I'll just go back to sharing my screen. Hopefully pick up where we left off. Yeah, so first family tree, so we've gone for dominant, and you're right, absolutely. So it affects all generations, so it doesn't skip any generations, and it affects both males and females, and every person who is affected has an affected parent. Generally, autosomal dominant conditions are where you have one mutated or one affected gene of your two copies, but you can very rarely get homozygotes, so where they've got two affected copies. And for a dominant condition, that generally means they've got a more severe form of the illness. So autosomal dominant conditions, I generally think of them as being kind of structural diseases. So if you have one healthy copy of a gene and one bad copy of a gene, you're effectively losing kind of 50% of its function. And so that tends to kind of link with structural things. If you've got 50% of the structural protein functioning, you can still kind of have a bit of function. And it kind of fits that logic a little bit. You're presenting with a I'm just going to make sure everybody's muted so we don't get a bit of feedback. So if you've got a list of conditions in an exam and they're asking you what kind of inheritance pattern it is, whether it's dominant or recessive, just think a bit about the disease. Is it a disease of structure, so affecting collagen, or kind of the structure of the body or the structure of organs, so kidney, and that might be more of a dominant condition where affecting enzymes or processes, so things like cystic fibrosis. It's more like a recessive condition, because it's really hard to remember from a full list of things whether they're recessive or dominant, but just thinking about what disease it is helpful.
It's not probably getting a bit of feedback.
Maha, are you able to mute yourself for us? Thank you. Great. So next one, so another family tree, what's the inheritance pattern of this one? And feel free to shout out and mute yourself to answer.
Is that also autosomal dominant?
No, gone for a different one.
It's recessive.
Recessive, yeah, exactly. Why do you think it might be recessive?
Well, it skips a generation for number 8 and 9. They don't have it, but they have a kid who has it, and then it's passed on by both males and females, so it's not.
Yeah, exactly.
Yeah.
Yeah, perfect. Fantastic. So it does affect both males and females, so it's less likely to be an X-linked condition, and to be affected, you need to have 2 copies of the abnormal genes, and if you just have one copy, then you're a carrier, so heterozygote, 1 copy, just a carrier. If both parents are affected, then all children should be affected, and we can see that from 10 and 11. So we've got 2 affected parents, so all of their genes are abnormal, so all of their children become affected. It can skip generations, which we see. So parents 1 and 2, their children themselves actually don't have the condition, and if one parent is affected, then the offspring that don't have the condition are carriers. So therefore, number 6 would be a carrier picked up from 1. So they have to inherit the abnormal gene from dad, and they will have inherited a normal gene from mum, so they'll become a carrier. And then when they marry 5 and have their children, it ends up being kind of quite a high chance that their children will be affected, and 13 have been affected. So autosomal recessive conditions, as I say, kind of affect in my mind, enzymes, processes, channels, all the kind of significant things that keep us going rather than structural diseases, so cystic fibrosis, sickle cell disease, long QT syndrome. So that's the problem with kind of channels within your cardiac tissue. So that's a kind of reasonable way to think about those and remember whether it's recessive or dominant. Any questions so far? Great. So next one. So what type of inheritance is this one? Yeah, this one's a bit harder.
Maybe X-linked dominant.
Yeah, why do you think that?
I think it's affected male and female.
Yeah.
And because it's and both affected male and female 7 and 8.
Yeah.
They have the disease, so all the children they have it.
Yeah, exactly.
Yeah.
Great. Perfect. So X-linked, this is X-linked recessive. So you don't get transmission from male to male. If the mother has one affected X, then she's a carrier. If she's got 2, she's affected. So 1, being a female, has 2 abnormal X's to be affected, and she then passes her abnormal X's to her sons. So 5 and 7 both end up being affected by the condition. Sons always get their Y from dad. So if mum is a carrier or is affected, if mum's affected, the sons will always get the abnormal X and be affected by the condition. If mum is a carrier, then the sons have a 50% chance of picking up the abnormal gene from mum. So males cannot be carriers of an X-linked recessive condition, and our examples are haemophilia and muscular dystrophy. They're quite hard to spot when you first see the pictures, I think. Okay, how about this one? Any thoughts on this one, just from what we've not covered so far?
How's everyone feel about it?
I think that one's the X-linked dominant.
Yeah, I think this one is, because this is all we've not covered so far. Great. So X-linked dominant is a really rare condition. So if you've got an affected male, then all daughters would be affected. So a dad will only give an X to a daughter. And if it's an affected X, then daughters will be affected if it's a dominant condition. So X-linked dominant, this number 1 up here, is more likely to have 1 abnormal X, but could potentially have 2 abnormal X's. And then actually they must only have 1 abnormal X, because 5 and 6 are unaffected, and 5 would have to be affected if mum had both abnormal X's, because they need to be XY. They will have got one of their X's from mum, so they must have got a normal X from mum. They had to get Y from dad. So number 1 must be 1 affected gene, 1 unaffected gene. So with X-linked dominant conditions, again, you've got no male-to-male transmission, because you completely lose the dad's X when you have a son, and the son is affected only if a mum is affected. So our example there is Fragile X syndrome. Okay. So moving away from our family trees, which of these is not a field of genomic medicine? And does anybody know what any of these are?
Surgical economics sounds the most made up to me, but...
Yeah, great. Cool. And what's pharmacogenomics?
The way that medicines interact with you individually based on something about your the way your genomic code gets read, I suppose?
Yeah, exactly. Is a medication going to work for you, or are you going to be more at risk of side effects? And we can work that out from knowing a bit about our genetics. Yeah, fantastic. Epigenomics, mentioned very briefly earlier.
How the environment affects the way that our gene codes are read, and over generations, what can affect which genes are read, which ones are not read, and can change. Yeah.
Exactly. So it's how our genes are controlled, so how they're turned on and off, and where they're turned on and off. And it can have an influence from the outside world. You're absolutely right. So smoking can have an influence on it. Drinking through pregnancy can have an influence on our genome, and there are kind of lots of conditions that affect the non-protein coding parts of our genome, and that kind of falls under the remit of epigenomics. How about transcriptomics? So that's the study of all. So when you make your DNA into your mRNA transcripts, people have studied all of those and found something very useful from them, I'm sure. Metabolomics and proteomics, they're probably quite similar. So that's just studying all of our metabolites within a cell or within a tissue, and same for protein. And then you're absolutely right, surgical omics, I just made up. That one doesn't exist. So we've been through the definitions there. So there's lots of ways to study kind of all the different parts of how we get from our DNA to our proteins and all of their functions. Okay, so how on earth is genomics relevant to primary care? A, it's not, you're crazy. B, it's relevant to so many things in primary care. Or C, it's the future of all areas of medicine. Any guesses? Please don't go for A.
It must be very relevant to everything. Yeah.
Yeah, great. So there's no correct answer, but I think B and C are sort of true. So currently genomics does have lots of roles in medicine, and it's got a lot of roles, particularly in cancer treatments. And as GPs, we do see a lot of patients with cancer. So it's good to have a bit of an idea of what's going on. And when you see the letters that mention complicated things, it's nice to have a kind of a reasonable idea of what they're doing and why they're having specific treatments that another patient with a very similar sounding cancer isn't getting. We do have an important role in identifying possible genetic conditions. So children experiencing developmental delay, they will often come to the GP first, and it's useful to kind of pick up on red flags and when to be a bit worried about that. ECGs, we see those all the time, often handed to you by the HCA in the practice when you're on duty, and it's good just to be able to have a quick glance and maybe pick up if there's any concerning findings and what you should do about that. We've definitely got an important role in taking a family history, and in things like kind of familial breast cancers or bowel cancers presenting in young people, then it's useful just to be able to ask a bit about the family history. And in the last years, there's been all this stuff about direct-to-consumer genetic testing, so such as 23andMe, that people might buy their dad as a Christmas present. You get a long list of results, and people could come and see their GP saying, oh, I've been found to have a gene for cystic fibrosis or a gene for dementia, and you might have to deal with that and work out what the best thing to do is. And then looking towards the future, so this kind of whole idea of personalised medicine, so having drugs which suit a patient's genes. So the kind of most relevant to us is statins. There are some genes that make you more likely to experience rhabdomyolysis from your statins, but actually it's probably not worth the money in terms of doing the genetic testing because it's such a small amount. And generally, if you just started it and they had some bad side effects, you'd just stop it and they wouldn't necessarily have any detrimental outcomes for that. So although it's a nice idea to work out somebody's genes and whether they're going to have that side effect or not, it's probably something way down in the future when these tests are much, much cheaper rather than paying for expensive tests for only a very kind of small market at the moment, but potentially in the future. Okay, so any questions so far? Great. So I'm just going to do a tiny bit that's a little bit less exciting, but I think it's still quite interesting. So just a bit of history on how we've got to kind of the current day with genomic medicine actually being a service within the NHS. So it's actually a fairly short history, I think, in terms of when we started to look at DNA and genetics. So some Swiss guy back in the 1800s identified the protein that turned out to be DNA, and he called it nuclein. And then a few years later, someone identified the bases and then provided the name DNA. It's got a fairly British history, which is quite nice. So we had Watson and Crick identified that it was a double helix. And then we had the first sequencing, so Sanger sequencing back in 1977, which actually is not that long ago. Then we have this whole area of next generation sequencing. It was just named because it was something different to Sanger sequencing, and it used all sorts of big fancy computers and was able to do things much quicker and on a much bigger scale. 2003 is when we sequenced the first whole genome, which actually at the time took 13 years and £2 billion. Whereas now, so 17, 18 years later, we can sequence a whole genome, a whole human genome, in less than a day and for less than £1,000. So absolutely kind of massive changes in technology and changes in what we're able to look at. So how did genomic medicine kind of become a thing, and why are we talking about it today? So back in 2012, when David Cameron was in the government, he initiated a project called the 100,000 Genomes Project, which had several aims. So they wanted to make the consenting process for looking at someone's genetic information ethical and transparent, and kind of form a good process of consent for using someone's genetic data or genomic data. And one of the aims was to introduce a new genomic medicine service into the NHS, which actually does exist, accessed largely through kind of the specialty of genetics, but also in cancer services and in paediatrics. They can send away samples for whole genome sequencing now. It's enabled some new scientific discovery, and it's kick-started a kind of UK genomics industry. So it had two arms to the 100,000 Genomes Project. So actually it started with three, so it's meant to be cancer, rare diseases and infectious diseases, but the infectious diseases arm kind of got lost along the way, and it's just really focused on cancer and rare diseases. So in cancer, they had 25,000 patients, and you looked at two genomes. So one was from the cancer itself, so a sample from the tumour, and then that was compared to patients' healthy cells. And with that, you could look at what were the changes that caused the cancer, what changes are there that could be a target for treatment, and that is used today to help guide our treatments in cancer care. So that made up 50,000 genomes of the project. And then we had 17,000 rare diseases patients. So for that, you need to look at three genomes. So you do kind of testing of what's called a trio. So you have the patient themselves, which is often a child presenting with a rare disease, and then you pick their two closest relatives, so generally both parents. That can help to identify a cause of their rare disease, and it has done so in a few people, but also to help identify new treatments. So that's more for kind of scientific research and people in the future that may have the same disease, rather than actually a treatment that's going to benefit those that entered the study. And they were consented and kind of knew that all along, that it would be, they may get a diagnosis, but they may not have access to a treatment, and the treatments are kind of something for the future. So there were, of course, challenges with the 100,000 Genomes Project. So it created absolutely massive amounts of data, and that gives problems with storage, interpreting the amount of data. So one person's genome kind of fills more than your average computer, and also security of keeping that data kind of confidential and only accessed by the people who need to access it. So in terms of interpreting the data, you also need to know a little bit about the patient. So what kind of, were they male or female? What kind of symptoms did they have? And you need to put that together with all of your genetic information. So that's obviously a time-consuming process. And what comes out of that needs to be actually useful for the doctors that are treating the patients. With cancer, one of the challenges was in preserving the tissue samples. So unfortunately, in the early days of the study, lots of tissue samples were lost just because they weren't preserved correctly. I think they were put into formalin, and that damaged the DNA, and so there were quite a few that didn't get answers early on in the study, and then later they decided to just do kind of fresh frozen samples, which meant that a lot of hospitals within the NHS across the country had to change what they did in terms of operations and biopsies and getting all those samples sorted. So there was lots of kind of logistical challenges along the way too, and the process of making sure that patients are consented correctly for all the possible uses of their data. So when it first started in 2012, there were kind of different uses to what there might be now. So there might be new commercial companies that want to make a drug, that want to access data. So it's a challenge in terms of consenting for future uses as well as current uses of all of that information. So what have we actually gained, or have we actually even gained anything so far? So there were some quite good outcomes. So 1 in 4 of the rare diseases participants actually got a diagnosis, which I think is pretty good, 25%. And half of cancer patients actually had an actionable finding. So that was that they could then take part in a clinical trial, or that they could receive a pre-existing targeted therapy to treat their cancer. And the main outcome of this project is that there is actually now this genomic medicine service in the NHS, and whole genome sequencing is a possible test for cancer and rare diseases. So actually kind of it's given us an improvement in things that patients can access within the NHS. So something good. How's it relevant to us? So you may have already seen reports of people that have been through the 100,000 Genomes project, or have it mentioned in a letter, and sometimes you may even see the kind of genetic reports showing what they found and whether they thought that that was something significant or not. Patients at the time could also be consented to have additional findings. So essentially, even though they were sequencing the whole genome, they weren't necessarily reading the entire part of it. So they might have done kind of panels of genes that might be related to the cancer type that they had, or the kind of disease presentation that they had. Even though they sequenced all of the information, they've kind of just stored it and it's available for use at a time when we know a bit more about all of the DNA. But so it was kind of focused. So patients could consent to have additional findings looked at. So that was for kind of common cancer syndromes and carrier status. So only if both partners were in the project and had their genome sequenced. So if you had a kind of trio in rare diseases, if both parents had their genomes tested, they could also consent to have things checked for, like carrier status of conditions such as cystic fibrosis. And with this, there may also have been some incidental findings, so such as non-paternity. So that's when you find out that your dad is not your dad, and that was something that actually came up in the trio testing, so for your rare diseases. And then you enter that kind of difficult position of how to tell them and who gets the job of doing that. I don't think that should ever fall on us in primary care, but that's, I'm sure, quite a challenging conversation. So any thoughts of conditions that kind of you might come across in primary care?
Hemochromatosis.
Yeah, fantastic. That's on my list. So great, thank you. Anything else?
Marfan's.
Yeah, I could do. Pretty rare, but definitely.
Cystic fibrosis.
Yeah, could do.
Turner's.
What was that one?
Turner's, isolated with Turner's syndrome.
Oh yeah, that's really interesting. Great. So I'm going to cover 2 today. So hemochromatosis is one of the 2, and the other one is familial hypercholesterolaemia. Yeah, great, thank you. So we're just going to cover these 2 today and go in a little bit of detail about them. So just starting with hereditary haemochromatosis. So it's an autosomal recessive condition, and it's due to mutations in the HFE gene, and that has a role in how we absorb iron from the gut. So it leads to increased absorption of iron, which then accumulates in various organs, so liver, heart, pancreas, skin, joints, gonads, thyroid and pituitary gland, and it can therefore present with conditions affecting kind of the iron being stored in all of those different organs, or it can just present with kind of general vague symptoms of being a bit fatigued, being a bit tired, potentially having a bit of tummy pain. So do consider just kind of checking someone's iron in these vague presentations. And it also fits with, someone tired all the time. Are they just anemic with low iron, or you get a raised iron result back? Maybe just think of this kind of in your list of differentials. The classic kind of trio was diabetes, so bronze diabetes because people are tanned, with liver failure and having a tan. That was the kind of classic trio. It's not really seen anymore because you tend to pick it up earlier on in the kind of disease process. So men tend to kind of be picked up earlier than females. Women are generally kind of postmenopausal when it gets picked up, and that's because having a monthly period before your menopause is kind of protective, so you'll lose a bit of iron just naturally by having periods. So men tend to kind of present at a slightly younger age. So kind of what sort of blood test would be suggestive of haemochromatosis? So you're looking for the raised ferritin level. So greater than 300 in men and greater than 200 in women can be kind of supportive or suggestive. But do remember that ferritin is an acute phase protein. So if someone's got an infection on board or inflammation or any sort of underlying cancer, then that can give a raised ferritin as well. So just consider whether it's raised for any other reasons and what the rest of the bloods are showing. So if it's just an isolated raised ferritin with kind of no clinical worrying picture otherwise, then you want to do your iron studies, and that's where you look at your transferrin saturation. So transferrin is what iron binds to in the blood, and a percentage greater than 45% would fit with a possible haemochromatosis diagnosis. Looking at your LFTs is also really helpful. So you may have a raised AST or ALT or kind of hepatitis or hepatitic type picture, and that's just due to the accumulation of iron. And it's thought to kind of act in a sort of oxidative response type of way. So it's inflammatory, having all that iron stored in your liver or any other organs. So when you've got that picture, so your raised ferritin, your raised transferrin saturations, possibly some abnormal LFTs, you then want to think about doing a genetic test to look for haemochromatosis. And we can actually do that genetic test from our primary care surgeries through Exeter Lab. So the Exeter Clinical Lab is actually a really good resource. I don't know if anyone's used it already at the moment, but if you're ever looking for a certain type of test, the lab website is quite helpful at telling you what tube you need, is there a special request form, and for haemochromatosis you can actually send a sample off for genetic testing for the HFE gene, and there's a form that you fill out just from the website, and it tells you that you need 2 purple tubes. One of my colleagues has done this already. He says the result comes back. It takes about a month to come back. And he just put, in terms of the funding, he just put Devon CCG and had no problems from that. And it all got through okay. So I'm assuming we can all do the same and we'll get our results back. So once you've sent off your genetic test, when the result comes back, you will be told kind of various outcomes. So it may be that they don't have a genetic abnormality at all, and then you just need to think elsewhere as to what's going on, or maybe the results weren't that convincing. Or if you're totally convinced, you can still speak to genetics if you think that it was just kind of a false result. But the results you may get back are a C282Y mutation, which is the most common mutation causing hereditary haemochromatosis, and it can either be as a carrier or as a homozygous person, so then having 2 abnormal copies. So homozygous having 2 abnormal copies, they tend to fare more badly than those who are carriers, but carriers can still also have problems. So if you've got your kind of homozygous, so 2 bad copies, they're the ones that need to go to secondary care, and your carriers can actually be managed potentially more in primary care by just monitoring their iron and only referring them for treatment if their iron is kind of persistently very high, or you think that they need something to reduce that. So the results come back with similar kind of information as you see here. So the management, as I said, just depends on the genotype, whether you've got 1 bad gene or 2 bad genes, but it tends to largely be under haematology and gastroenterology. So the way that we reduce our iron levels is to kind of get rid of a bit of blood, so venesection on a regular basis. So at the start, it may be slightly more regularly, so say weekly, until you get the iron levels down to a reasonable amount. And then you may just have maintenance venesections, say 2 or 3 times a year. And that will just be managed by the haematology department generally. For those that can't tolerate having kind of the venesection, then there are iron chelating medications, but these would be started by the specialist in the hospital rather than by us in primary care. And an important part of having any kind of genetic diagnosis is considering genetic counselling. So that's so that families can be supported in terms of kind of having children in the future. And the Haemochromatosis UK charity is really good for providing kind of free genetic counselling for people who are affected. So it's well worth just signposting people to that charity for support. Okay, so
Helen, can I ask a question about, or well, I don't mind. Do you want to ask now or at the end?
Yeah, no, now's great.
So I had a patient who had a multitude of sort of various symptoms. We did lots and lots of blood tests on her, including ferritin and iron studies, which all came back as normal. And so we didn't find a cause for her multiple symptoms really, which was for part of her frustration, I think. But her son had similar symptoms and had been diagnosed with hemochromatosis. So she was very, very worried, partly that she had it, that we hadn't found it, and also very, felt very guilty because she'd read up about it, that she'd given it to him.
Yeah.
Now, according to the formulary, which I can't find where I found the information, but on the formulary it says if they've got normal ferritin and normal transferrin and iron binding and things like that, that you don't need to refer them for any further genetic testing or anything more, and you can reassure the patient. So we tried to say that the blood tests we have done on several occasions have all come back normal. We don't need to do any more testing for you. But I don't feel that she really was satisfied with that answer, and there was still that question in her mind about whether it had been missed, that even if her results were normal, she still had that gene. And that she'd given it to her son. So would it have been appropriate to have either gone through the genetic counselling route to help her to look, ask those questions about it in more detail, or have gone and done that genetic testing if we can just sort of send it off anyway?
Yeah, so I think the difficulty with getting the test is that the form does specify that you've got to put in the iron levels and put in the transferrin saturation. So she probably would have got through for testing herself. You kind of want to know, has the son, is he homozygous or heterozygous? So if he's homozygous, then he must have got the abnormal gene from mum. I mean, you can of course get sporadic mutations, so it's just kind of occurred off chance rather than actually being inherited from mum. But if he's got 2 abnormal genes, then one should have come from mum. I guess if mum had particularly heavy periods, then her iron levels may not be so high, but the transferrin saturation should probably still be at least at the upper limit of normal for her to kind of be affected by the condition. But she may well just be a carrier and they are not necessarily affected so much. I think essentially with that family, referring them to this charity for some genetic counselling may be a reasonable idea, if not advice and guidance to actually extra genetic service saying what's happened with the son, she's really worried about it, is there anything else that you can do, or would you suggest that we organise a test, because they may be able to get the test done kind of going away from the form that we can use in primary care. They may just be able to do it anyway.
Okay, that's really helpful. I mean, I'm not unfortunately not working at the GP surgery anymore, but I could let one of my colleagues know. I could let them know. They may not be it may not be on their radar to think about the genetic counselling.
Great, interesting.
Thank you, Helen.
Interesting case. Great. Any other questions about hemochromatosis? Cool, and then we'll move on to the exciting world of familial hypercholesterolemia. So this is an autosomal dominant condition that leads to raised levels of cholesterol, actually from birth, leading to premature cardiovascular disease. So strokes and MIs at a really young age, and it's actually massively underdiagnosed. It's quite prevalent in Europeans, so 1 in 500 people have it, and we probably see lots of raised cholesterols that we don't necessarily think too much of, but red flags would be seeing a cholesterol, just a random total cholesterol greater than 7.5, or someone having a cardiovascular event at an age less than 60, and that can be themselves or someone having a kind of relative that's had a cardiovascular event less than 60. You might want to think about checking their cholesterol as well. So what tests can we do in primary care? So we can look at the LDL cholesterol, so one of the kind of subsets of our lipid profile, and consider a clinical diagnosis of familial hypercholesterolemia if you've got results greater than 13 in an adult or greater than 11 if they're under 15-year-old. And the clinical signs, as we remember from medical school, are those tendon xanthomata, so kind of yellowy, fatty deposits on tendons, particularly the Achilles tendon is a good place to look. There's lots of different things that can raise your cholesterol, so it's worth just doing some blood tests to screen for those other causes or looking at the medications list. So hypothyroidism can put it up, having cholestatic liver disease such as your primary biliary cirrhosis, so consider that as an alternative diagnosis. Nephrotic syndrome, so that's a kind of range of conditions that cause your nephrotic syndrome, which is characterised by low albumin, peripheral edema, and proteinuria, and there's loads of different conditions and drugs that can cause that. Cushing syndrome puts up your cholesterol, as does anorexia nervosa, the eating disorder. Loads of drugs can do it, so actually quite common drugs, so thiazide diuretics, beta blockers, and your isotretinoin. So if you've got someone with acne on that and they've got high cholesterol, it's probably just the drug rather than them having familial hypercholesterolemia. Diabetes can up your cholesterol, so can excess alcohol, and so can HIV. In terms of diagnostic criteria for FH, so Simon Broom is probably the most well-known one, but there is a Dutch one which is slightly more complicated, and the Dutch criteria actually take into account the genetic test. So this is the one that's much more useful for primary care. So largely it's looking at the cholesterol level, so a level greater than 7.5 is our kind of cutoff, and the tendon xanthomata. So if you've got 1 + 2 or 3, which is a kind of DNA evidence, then it's a definite familial hypercholesterolemia. If you've got raised cholesterol plus a bit of a family history of something that kind of sparks off cardiovascular disease at a young age in your mind, then they may have a possible diagnosis of FH. So if they fit the criteria, you can make a kind of clinical diagnosis of familial hypercholesterolemia, but you then want to refer them to a specialist to confirm the diagnosis and to arrange testing of the family as well. In terms of the specialist to do that, that can either be clinical genetics, which there is a team at Exeter, or there's actually a lipid clinic, not at Exeter, unfortunately. There's one in Torbay, but we can refer to them. It's really important to pick it up in the family, because in children you want to start treatment really early, and you want to make that diagnosis ideally by age 10, so kind of early doors for treating children. In terms of genetic mutations, so they tend to affect the kind of cholesterol synthesis pathway, so your LDL receptor, apolipoprotein B, also involved in all that pathway, and the PCSK9 genes. So cholesterol is one of those things that where actually we don't get it in very large proportions from our diet. We make our own cholesterol in the liver. So if you have mutated lots of things along the kind of processing of cholesterol, that's how we end up kind of making more of it, rather than it's not that we're absorbing more of it, we're just making more of it. So in terms of management, again, it depends on the genes, so whether you've got 1 bad gene or 2 bad genes. So having 1 bad gene is a slightly more manageable in primary care, that the outcomes may be not quite as risky, and it's worth just addressing all those modifiable risk factors and ensuring that you've got a baseline ECG on the system as well. So looking at smoking, obesity, that's meant to be blood pressure, not BO, and then you can prescribe them a statin. So we use the term high intensity statin, which generally is a atorvastatin 20, or if they don't tolerate that, you could try rosuvastatin. And you want to look at the blood results, so you're aiming for a 50% reduction in their LDL cholesterol, and it's reasonable to check that in kind of 2 to 3 months on starting the statin. And ideally, you want to have done some blood tests before you start a statin. The advice is that you should only check a CK before starting a statin if someone already has muscular aches. It's not recommended that you check a CK before putting them on a statin, unless they're kind of someone who's got general muscle aches and pains. You would then want to check it if someone develops aches and pains and kind of general muscle aches when they've started the statin, but you don't necessarily need a baseline before. But if you were looking for all the other causes of raised cholesterol, you'll have done your checks for diabetes, you'll have done your thyroid function and your LFTs, etc., as kind of part of your whole workup. So those bloods are a useful kind of baseline when you're starting a statin. If someone has 2 bad genes, so they're homozygous for familial hypercholesterolemia, then those are the ones that you want to refer to the lipid clinic for specialist management, because they tend to go on to a statin plus something else, so something that helps kind of sequester your bile acids or your fibrates, and they are kind of secondary care prescriptions rather than something that we would start. You can also do LDL apheresis, which is where it's kind of like dialysis but for your LDL, so that's just taken out of the blood, and also a liver transplant is one kind of option for people who are severely affected, and that is because we make our cholesterol in our liver. If you give someone a different liver that has cells that don't have your familial hypercholesterolemia affected genes, then it should not produce the excess cholesterol. So that's the thought there. And I guess actually if you end up with really abnormal LFTs, or you end up with liver disease from having your very high cholesterol, you may end up in a position of needing a liver transplant far down the line. But actually the thought is that you do it earlier, just so that you kind of have more normal cholesterol synthesis rather than the abnormal one in familial hypercholesterolemia. Children should be managed in secondary care, and ideally they should be started on a statin by age 10 or as early as you possibly can. Nice CKS is quite good for familial hypercholesterolemia. I think that's a good resource generally, useful for AKT and useful for your RCA in the future as well in terms of management. But if anybody needs a QI project idea, which is something you guys have to tick off for your portfolio, then this might be quite a nice audit on the GP system. So just doing a search for people who have high cholesterol, seeing have they kind of had this looked into, because it is quite a common condition and we do miss lots of diagnoses. So if you were to just do a search of patients under a certain age and see if they've had a cholesterol check and just make sure that that's been followed up on, you probably wouldn't get huge numbers from it, and you may pick up someone who actually hasn't been diagnosed. So just a project idea there. Great. So next what we're going to do is put you in some...
There's one question related to...
I can't see the chat, sorry.
So this is from Chizubi. In what time frame do we aim for 50% reduction in LDL, and how frequently do we recheck cholesterol levels?
So I would suggest once you started them on it, testing it at 2 to 3 months. And we always give people kind of vague time windows for blood tests in primary care, because in terms of people actually booking an appointment, and you don't want to put pressure on the system and saying you've got to definitely have this at 8 weeks. So give someone a vague time frame. It doesn't really matter. Have a look at the results in 2 to 3 months. If it's come down, fantastic, continue at that dose. If it's not come down and they're tolerating the statin, you could always increase it. So instead of atorvastatin 20, you could go up to atorvastatin 40 and see if that helps bring it down. And again, just recheck it in a reasonable amount of time, so another 2 to 3 months. I think that would be kind of reasonable. Great. Any other questions in the chat?
No.
Perfect. So in terms of the AKT, so the RCGP super condensed topic guides are a really useful resource actually for all of the areas in the curriculum. And the one on genomic medicine says that the following may appear in the AKT. So interpretations of genograms, so we've done a bit of that already. So hopefully you're all experts. Recognising presentations of common genetic conditions in primary care, and also looking at consent, capacity and confidentiality of genetic testing, which we've touched on a little bit in our history lesson. And now, hopefully, if you just go onto the chat and download that file of AKT questions, we're just going to work out putting you into some breakout rooms, and then we will give you, what's the time? So it's 11:30, so we just give you 15 minutes in your breakout rooms, and then we'll all come back together and go through the answers together, if that's okay. So question number 1, so you see a family, a woman whose family have got Haemophilia A. Which tree is most in keeping with this? Does anyone want to have a guess? What did you go for?
I think we had a discussion in the previous group, and I think we thought it will be the E.
Great.
Because it is X-linked recessive.
Perfect. Did other groups get E as well? Few nods. Fantastic.
Yep.
Perfect. Yeah. So it's E. So haemophilia A is X-linked recessive. If you know that it's X-linked recessive, then you can work out which family tree fits. So the parents at the top of this tree must be the carriers. They then have an affected son. The daughter must be a carrier to go on herself to give the affected son. Sorry, the parents, the female must be a carrier. The male is unaffected, so he must have a normal X. Perfect. As we went through right at the beginning, you get no male-to-male transmission because it's X-linked. Recessive, if the mother has one affected X and she's a carrier, she's got two, she's affected. If the female is affected, then all of her sons will be affected and daughters will be carriers, and each son of a female carrier has a 50% chance of being affected, and males cannot be carriers, they have to have an abnormal X. If they do have an abnormal X, then they are affected. So great. Question number 2. Oh, just a bit more on haemophilia A. So it affects the synthesis of clotting factor 8. So patients present with increased bleeding time following an injury, following surgery, and they can also present with hemarthrases, so such as a big red swollen knee joint full of blood. Blood tests will show a prolonged APTT. A third of cases are actually sporadic, so they don't necessarily have a family history. So your family tree may not look perfect if someone in the family has then developed sporadic mutation, but they then, of course, can pass it on to future generations. Treatment tends to be with factor 8 concentrate, so that can either be as a regular infusion for those who are more severely affected, or just for those when they're actively bleeding, because it can be a kind of spectrum of how severely affected people are, depending on how much of their factor 8 they're producing. And there's a bit of variability in terms of what genetic mutation that you have and how much functional factor 8 you produce, which is why treatment is kind of dependent on the severity of your symptoms. So very mild disease can actually just be treated with desmopressin, which is a medication that we commonly use in children for bedwetting, but it actually releases stored factor 8. So that can be used in very mild cases. Okay, great. Question number 2. So this 17-year-old has progressive clumsiness and speech disturbance for 3 months. She's got some very mild jaundice, a slightly enlarged liver, and this is her eye. So what would be the blood test or the next test that you're going to think about doing for this person?
Is it B? Serum ceruloplasmin.
Yeah, great. And what's going through your mind there?
Wilson disease.
Fantastic. Great. Yeah, so you're going to check your ceruloplasmin, so looking for Wilson's disease, and those that I was showing your Kaya-Fleischer rings, so that's this kind of copper ring just around the outside of the eye there. So it's a multi-system disorder. It affects young people, and kind of one of the signs that you might see is the Kaiser-Fleischer rings. So Wilson's disease is abnormal copper handling, where copper then accumulates in the body, and the symptoms that you get are characterized by kind of where that is stored. So it's stored in the brain, causing your kind of clumsiness or your neurological symptoms. It's stored in the liver, causing cirrhosis and increasing your risk of hepatocellular carcinoma. You get a big spleen, it's stored in there. And the movement disorder is kind of from the deposits in the brain as well. And it can affect mood and give you kind of a dementia type picture and altered personality. It's a low blood ceruloplasmin that's associated with Wilson's disease as well, rather than raised, which you kind of might classically think of. So it's stored in the organs, it's therefore low in the blood, if that makes sense. High in the organs, low in the blood. Perfect. Question number 3. So this 22-year-old woman comes to see you for a routine review. She
Is it Peutz-Jeghers syndrome?
Yeah. Very keen to answer there.
Good job, Amjad.
Perfect. Good. Well done. So it's Peutz-Jeghers syndrome. So that's a mutation in the STK11 gene. So it's characterized by these haematomas and the melanocytic macules, which you saw on that patient's lips. So they affect lips, gums, or mucous membranes. And this condition is associated with lots of polyps, so haematomas in the GI tract, and these are all pre-malignant, so they will go on to develop bowel cancer if it's not treated. And you're also at risk of lots of other different sorts of cancers. Cool. Great. Question number 4. So which of the following statements about Huntington's disease is true?
E.
E. Yeah, everybody get E. And what's that phenomenon called?
It's anticipation.
Anticipation, exactly. Great. So it's E, so successive generations can be more severely affected. So Huntington's disease is an autosomal dominant condition. It's known as a triplet repeat disorder. So repeats of lots of runs of CAG, and it exhibits anticipation. So successive generations are affected at an earlier age and more severely, and that's purely because the triplet repeats get longer. So younger generations have more repeats. So it's a longer length of repeats, and that makes you be affected at a younger age and also more severely. This condition generally manifests at kind of post-reproductive age, although successive generations that will obviously get younger, but that's how it tends to spread in families. People have already had their children before they realise that there's Huntington's in the family. Question number 5. So colorectal cancer is the 3rd most common cancer in the UK. Some cancers are predominantly environmental and some are hereditary. So what kind of percentage do you think might be due to the inherited cause of familial adenomatous polyposis?
I'm not sure, but I will go for 5%.
5%, okay. Any other offers? Do you think it's that high? 5% sounds like quite a lot. Okay, so 0.5% is actually a really small percentage of bowel cancers that are caused by this inherited condition. There's obviously a few other inherited bowel cancer conditions, so but overall in total the amount of hereditary bowel cancers is much smaller and much less than the environmental types that we see. So FAP is a condition which is autosomal dominant, affects structure within the bowels. Hundreds of thousands of precancerous polyps develop actually from teenage years, and the mutation is in a gene called APC, or adenomatous polyposis coli, I think it stands for. And generally in people that have this condition, they should have a prophylactic colectomy before the age of 25. So pretty significant surgery. So really important to pick this up at a young age. Okay, question number 6. So a couple come into the surgery for preconception counselling. They're both known to be carriers of cystic fibrosis. What is the chance of a couple having an affected child with cystic fibrosis?
25.
Everyone agree? Great. Yeah, 25%. So it's autosomal recessive. So both parents are carriers. 50% chance that the next child will be a carrier, and 25% chance they'll be affected. 25% chance that they will be unaffected and not a carrier. And in my exams, I always used to draw these little tables, the 2x2 tables, to help work out your percentages. So if we go for big C as having cystic fibrosis, little c as not, etc., you can kind of work it out from there. Question number 7. So potentially you didn't quite get this far, so we can have a look at this one together. So in the UK, babies are screened for a range of 9 conditions on the newborn blood spot test. All of the conditions are autosomal recessive, except for congenital hypothyroidism, which tends to be a sporadic mutation. If neither parent suffers from the condition being tested, but the child is found to have one of these autosomal recessive conditions, which of the following is true? So A, one parent only carries the faulty gene. B, all future siblings have a 25% chance of being a carrier. C, all future siblings have a 25% chance of also having the condition. D, only females can genetically pass it on. Or E, none of the above.
C.
Think C, yeah.
Yeah, great. So C, so all future siblings have a 25% chance of having the condition. So in the question, if someone is affected by a recessive condition, both parents must be carriers. Therefore, looking back at the cystic fibrosis table that we had, any future siblings would also have a 25% chance of having it too. In contrast to autosomal dominant conditions, usually it's one parent that's affected and 50% of the offspring will have the condition, given that the dad will either give one or the other, so half of the children will get the abnormal ones. Mitochondrial inheritance, that affects both males and females, but as we mentioned right at the start, the conditions are only inherited via the female line. Okay, question number 8. So you've referred a 14-year-old girl to genetics after concerns regarding slow growth, low set ears, a webbed neck and obesity. Her chromosomal profile has been identified as 45XO. So firstly, what was that condition? Can anybody tell me? And which of the following is a possible complication?
Turner syndrome.
Osteoporosis.
Yeah, great. And what's the kind of logic behind that?
Because she's got Turner syndrome, they have strict gonads and like failure, and like so she lack estrogen, and then that would predispose to osteoporosis.
Fantastic, that's exactly correct. So it's osteoporosis. So girls with Turner syndrome have primary amenorrhea and therefore very low estrogen levels, and that can predispose them to early osteoporosis. There's lots of other complications that they can get. So they can be born with congenital heart defects. They're at risk of both types of diabetes, high blood pressure, and urinary tract abnormalities. So they often end up kind of having imaging of their renal tract and kind of urinary system just to look for any abnormalities there that are quite common. They're also at increased risk of deafness and thyroid problems and just general autoimmune diseases. Treatment tends to be along the lines of growth hormone, but also estrogen therapy. So kind of giving them something like the combined contraceptive pill or even HRT to protect their bones largely. And it also gives kind of cardiovascular benefits and some benefits with diabetes as well. So question number 9, this is a kind of drawing lines between one half and the other to match the condition with its inheritance pattern. So I'd say actually the top one is probably the trickiest. Does anybody know what alpha-1 antitrypsin deficiency has as its inheritance pattern?
Autosomal recessive.
No, it's not actually. So the logic would be that it's kind of fitting an enzyme or a process in the body, so recessive would fit better, but unfortunately it's not one of those.
Or dominant.
Multifactorial.
Sorry, I just didn't catch that. Did you say dominant or co-dominant?
Co-dominant.
Co-dominant, yeah, it's co-dominant actually. So it tends to be that both parents pass on an abnormal gene, but they may have different mutations each parent, so it tends to be co-dominant. Cystic fibrosis, we know that one. Someone shout out for me.
Autosomal recessive.
Yeah, fantastic. How about familial combined hyperlipidemia? So that's quite a rare condition. We've not talked about that already. Yes, I think it is actually. We'll double check on our next slide. Duchenne's muscular dystrophy.
X-linked dominant.
Close.
I think it's recessive.
Yeah. Huntington's disease.
Dominant.
Autosomal dominant.
Yeah, brilliant. And then sickle cell anemia.
Autosomal recessive.
Cool. Great. So cystic fibrosis and sickle cell anemia are autosomal recessive ones. Alpha-1 antitrypsin is co-dominant with 2 different mutations. Your familial combined hyperlipidemia is dominant, as is Huntington's. And then the Duchenne's muscular dystrophy is X-linked recessive. Well done. So question number 10, this is our last one. Which of the following is true? So conditions which are lethal in early childhood are most commonly autosomal dominant. For a given autosomal dominant condition, the changes of a offspring developing the condition, the chances, sorry, that should be chances, not changes, of an offspring developing the condition is 75%. C, X-linked dominant conditions are more common than X-linked recessive. D, for a given autosomal recessive condition, the chances of unaffected offspring being a carrier is 25%. Or E, female carriers of X-linked disorders sometimes exhibit symptoms of that disorder. Any thoughts?
Is it
John?
C?
Oh, okay, yeah. No, so X-linked dominant conditions tend to be less common. X-linked recessive is probably the more common type of those of X-linked.
I think E, female carrier of X-linked disorder, sometimes exhibits symptoms of that disorder.
Yeah, exactly. That's the right one.
Very rare. Yeah.
Yeah. So A, conditions which are lethal in early childhood actually are more likely to be autosomal recessive, and that's because they kind of affect those key enzymes, key processes that might keep somebody alive, basically. Dominant conditions can sometimes kind of present slightly later in life. X-linked recessive slightly more common than X-linked dominant, and female carriers of X-linked disorders can sometimes exhibit symptoms of that disorder. So for D, for autosomal recessive conditions, the chance of unaffected offspring being a carrier would actually be 50%. So if you're unaffected, you're either you've got normal genes or you're a carrier, so that's 50%. For a given autosomal dominant condition, the chance of an offspring developing the condition it should be 50% rather than 75%. Okay. So in terms of why female carriers can sometimes exhibit the symptoms of the disorder, it's due to the phenomenon of X inactivation. So in all of our cells in our body, we don't necessarily need both X's, we just switch one of those off. If one of our X's carries an abnormal gene, your body will kind of naturally realise that one of those isn't quite right, and that's the one that will be turned off. But very rarely you can keep the abnormal X turned on rather than switching it off, and that can lead to some symptoms in those conditions. X inactivation is also why you only get female tortoiseshell cats as well.
Good fact.
And as we said, conditions which are lethal in early childhood are most more likely to be autosomal recessive. Great. So that's all of our AKT questions. Well done. Any questions from those questions or from anything else we've covered this morning? If you don't think of them now, but think of them later, then feel free to drop me an email.